Hello, and welcome back to the Doctoring Duo podcast. It's been a little bit. Sorry, we've been away for studying for step two, but we're back. My name is Eleni Fafudis. I am now an M4, isn't that scary? At Penn State College of Medicine. And as a reminder, I do not speak for my school, only for myself.
Yeah, hey everybody, good to see everybody again. It's been a long time. Noah, I'm one of the now fourth year students, just like Eleni at Mayo Clinic. Finished up our third year in step two, and just like Eleni said, I speak for myself and not my institution.
All right. Well, we're going to have a step two episode once Noah gets his score back. I'm sure he did great. But for now, we're going to focus primarily on how to honor your internal medicine and surgery rotations, two of the most considered difficult rotations. Kind of said that weird, but the hardest ones to honor just generally. I think we both got honors in both, right?
Yep, I think we honor both, so good for us. Kudos to
Right.
us.
I know. A lot of hard work and maybe a little bit of luck, I think. So which one do you want to start with?
Yeah, why don't we start with internal medicine? Because I think for you is actually your first rotation, right?
It was my first rotation. Yes. I was really nervous about it. Wasn't sure. I'd kind of known I wasn't going to do internal medicine. So it kind of made life a little easier. But yeah, long hours. My roommate actually, she's on her internal medicine AI right now, and her hours now are better than when she was on her internal medicine rotation. It was like 6 a.m. to 6 p.m., 6 out of 7 days a week. So expect hard hours. I think one of the biggest like saving graces for me for internal medicine was that I started UWorld basically day one, and I divided it out like throughout every single day of the rotation. And so, I was able to do like, 30, 40 questions a day because there's 1,200 of them, I believe, in UWorld.
Yeah, I think what you just said is definitely one of the keys to success is starting your world early and starting it consistent and keep on a schedule. Because the shelf, I think, is probably one of the hardest. In addition to just being your hours, like you said, like 6 days a week, you're usually doing 6 to 6. The shelf is also a killer. So making sure that you start your world early, especially when you come home tired at 7 o'clock at night and you still haven't had dinner and you got to get up and do it all again the next day, is just making sure you get on a routine and that you can fit all those questions in.
I think one of my keys to success in internal medicine, at least if we're going to start with like study resources and
Yeah.
studying, I really liked the Step Up to Medicine textbook. Really, really like that book. I think it's actually one of the few like indispensable textbooks for clerkships. Like I think you have to use Step Up to Medicine. That's how good it is. So highly, highly recommend getting that textbook.
Yeah, that's actually a really great resource. I actually didn't use that. I think I was a little bit boring and I sticked with Boards and Beyond back from our step one days. I found that to be useful, but um, I think you probably did a lot better on the shelf than I did. So I'd definitely go with one of Lenny's. I didn't use
I did
step
okay. I
medicine.
did okay. Nothing to write home about, enough to get the grade I wanted. But I will say Boards and Beyond makes a companion textbook for all the shelves and the step two, which is called the White Coat Companion. I would have to say if you want to pick just one textbook and stick with it all the way through shelves and into step two, I used it for all of my shelves and step two, and it was a very good decision. You don't need to watch Boards and Beyond to get it. Like I just bought it off of Amazon. I think Boards and Beyond videos are very good, but they do put me to sleep a little bit. So even on two times speed. So I really, really like that resource because it was organized extremely well. It was extremely easy to look things up, and it only had the high yield information in it.
Yeah. So I guess as far as like, so we've talked about study resources and the shelf is definitely a killer. Definitely, it's going to focus a lot on your major organ systems like cardio, respiratory, GI, and such, infectious disease too. But as far as succeeding clinically, what would you say really like set you apart from other students?
That's a hard question, because I was really inexperienced, right? I didn't know anything. It was my first rotation. I think coming in and always giving an earnest effort, right? That's kind of generic general advice. I think for internal medicine, like really seeking to like improve your physical exam, really working on like differentials. Like I think differentials are a huge thing in this and like management as well, because you're managing like oftentimes like 8, 9, like 10 comorbid conditions. And so I think like asking for feedback, and especially about like how I'm making my plan, like what I want, to do this, what I wanted to do that, I think is really like a key for success in internal medicine is like not getting lost in the sauce, like keeping your notes together and like being very intentional about like, okay, this is the problem that I'm addressing and this is how I'm going to address it. Um, so I think, that kind of segues into presentations as well. For me, presentations have always been a struggle point. I have a hard time kind of assimilating a large amount of information. And my presentations were obviously going to be the worst on internal medicine, right? Because that was my first rotation. And so I think like actively asking for a lot of feedback on those presentations was the key to my success. And like being willing to change and learn helped me get good clinical evaluations.
Yeah, I would definitely agree with that. I think I like your generic advice of just being, earnest, showing a willingness to learn, obviously show up on time, if not early. If you're given a task or somebody tells you to do it, then you should show up the next day and not be, have to be told to do it again. I think just in general, like you said, with presentations, I think for internal medicine, what's really hard, you're dealing with medically complex patients, and especially as like your first rotation. So not only do you have your acute issues for why somebody was admitted, like COPD or heart failure, then they have diabetes, they have et cetera, all these other chronic things that you have to think about and reconcile their med list. So I think one of the big things for medical students, as like especially as a third year student, is you don't have to get lost in the minutia of the entire patient's plan, but get the big picture of, okay, they have heart failure. What do I want to do to address their heart failure or their COPD? And maybe you don't know the exact dose of Lasix you want to give, but knowing that you want to give Lasix is enough at this stage, at least I found for most things, that attendings want you to know the big picture, what you wanted to do, what did you have a plan if something went wrong, and like, and one of the things that I think that is really helpful is go to like the junior and senior members of your team, like an intern or a senior resident, run by your plan, have them explain things to you. So then you can, be well polished for your presentation to the attending.
Yeah. Yeah, no, absolutely. And I think you make a great point is that I think students get really nervous about presenting plans because they feel like they have to know like XYZ. And I think that the main or like XYZ dosing, right? Or however, QD, QI, BID, whatever. I think part of that if like you want that detail, you can like talk to your residents. I think that I mean, in my experience, everybody's been willing to kind of help you and talk through it, right? But I think Noah like makes a really good point is that like try to have a plan because I think what kills a lot of students is that, at least on evals, is that not in real life, is that they are afraid to make plans because they're not certain of the specifics, right? And it's okay to not know the specifics, as long as you're making an earnest effort, right? And if you say, I want to hold this person's lisinopril. Okay, why? Right? If you can justify it, and even if it's wrong, I think that effort or that willingness to like do research and look things up really goes a very long way.
Yeah, I would also agree. And then I would also think one of the things that was common for students at us is like, you really assume control of your entire patient if your patient needs a consult for GI. You are the one who calls the GI resident or the attending and relays that information to the team. If you know that they're going to be um, a problem, maybe like there's some social situations at home and problems with discharge, you work with the social worker. So I think, and as a third year medical student, you're not going to know everything or know how to call a consult or even answer a page. It was so my first day of internal medicine, they're like, yeah, this is how you answer a page and this is how you call someone. And that's okay to like not know that, but those are skills that you learn and then you can build on that as you go through the rotation and like proactively take those steps, obviously with your senior, your attending's permission to before you call people.
Right. Yeah. Yeah. I remember we were sitting there and I was calling about like some imaging or something like that. And like they were all standing around behind me, like helping me make this call. And it really, unfortunately, the PA on the side of the phone was like mean. Maybe I don't know. Maybe she was having like a bad day or something, but like we heard them like making fun of me on the other side of the phone. And my senior resident like took the phone from me and was like, "Hey, I'm the senior resident. Like, what do you want?" Um, Anyway, most people are not mean. That's not the point.
Most people are not paid.
That's not the point to say. The point is that like if you ask to do things, I'm almost 100% certain that like your resident team is going to be supportive and like want to help you. And that was my point is that they're not here to see you fail. They will go out of their way to protect you and make sure that you're getting a good learning experience.
Yeah, most definitely. As far as like the amount of patients that you were carrying on service, what would you, and maybe it's slightly different between institutions, but how many patients were you carrying on average, probably a day?
At the beginning, like only one. I mean that's pretty typical. I
Yeah.
feel like for third year, they don't really up their expectations of you until fourth year. I mean maybe like two by the end of my main. How about you?
Yeah, for us, I would say I started at one and then I ended at about like three. One day we had like an intern was gone, one of our senior residents was gone, and then like the second year was like, "Hey Noah, you want to pick up like four patients for me today?" And I'm like, "Well, yes, I have to." Then you do what you got to do. But yeah, so usually I would say as a third year, anywhere from like one to four is typical, and then definitely if you're earlier, start with one and work your way up. And even if you're a super gunner and you want to do IM, I would still start low
Yeah.
uh, and build up before taking on too much responsibility and being overwhelmed.
I think there's like a tipping point between like when you start third year versus when you end, when you like realize that you become like helpful versus like time consuming. And I think that they start you with one not only because that's what you can handle, but also because they have to like double check everything that you do like more thoroughly. So I think yes, like that's part of workflow conscientiousness as well, right? And this is on any service, but I think in particular, I am like when you have like four or five teams of like different people and like they all have like dockets of like 15 to 25 patients, right? And you're like running half the hospital. I think it's like really important to see like where you fit in as a medical student and what your level is. Because they appreciate enthusiasm, but I would say like if you're just starting out, don't try to take more than one or two patients, right? Just because ultimately you do kind of slow down that pace of workflow if you don't know what's going on.
And it also gives you the time to truly think about like the patient and their entire clinical picture and to come up with a reasonable plan. As a third year, these are really some of the first times you might have read about it in the textbooks your first 2 years, but this is your first time you're actually seeing someone with COPD or heart failure, et cetera. So it really gives you the time to come up with a real reasoned plan. And even if one thing that I did was, we had Epic Haiku on our phones, like type up your note after you pre-round and I would have that to present with. So I'd have all their labs. Um, obviously I'd have my physical exam documented so I could have that all right there.
That's a really good idea. Yeah, I think writing the note kind of helps you shape your entirety of your presentation, right? Guides it. But yeah, I think IM was um a very challenging one because of how much you had to know. I think like I mean I don't know Noah you can share kind of what you think made IM most challenging. I think for me the added challenge was being my first one, but with that taken away, I think it was just there's so much going on. Like there's so much going on all the time versus when you're on like I don't know psychiatry, right? Everybody's like a psychiatry patient and it's like, "Oh, awesome." Like, if this person has coronary artery disease, that might be relevant in terms of like what antipsychotic I'm prescribing, but like in reality, like I'm not really managing like 800 things. I'm managing one thing. And I felt that IM was incredibly overwhelming for me because of how much you were managing.
Yeah, I think a couple of things make IM hard. One is definitely just the sheer like amount of things that are happening on, both on service, just in terms of like how many patients your team, like if you're capped and you have like 20, 25 patients on your service and everybody's scrambling, things are going on with your own patient, then you're working long out. So like the hours is another one, like 6 days a week, usually like 12, 13-hour days is another one. But I would agree. I think the most challenging thing is it's so broad. Just like I think the hardest fields in medicine tend to be like, either your undifferentiated patients like you get in like emergency medicine or family medicine. And then also just the sheer breadth. Like internal medicine covers just about every organ system.
Yeah.
So you have to know, just like family medicine doctors, you have to know at least a little bit about everything to be really good at your job.
And how do you do that on a third year level? You do
There
all
you
your UWorld questions.
go.
You try to do all your UWorld questions because that really is very important for this one. And, here's another insider tip is that step 2 CK is almost entirely internal medicine. I'm thinking back to mine. It was mostly a blur, to be very honest. But I had so many questions about like GI stuff, like
Yeah.
so many questions about GI. So, know it well. I think also the surgery shelf is very similar to internal medicine, right? Because they're not going to be like, oh, like what kind of suture are you going to put in? Like that's not really appropriate for the level on surgery, but they are going to be like, oh, this person is like status post hepatectomy or like secondary to, whatever XYZ disease. And it's very internal medicine-y.
Yeah, and this, I feel like internal medicine, and then this is actually a nice transition point to surgery too, is to start getting into the mindset of next best step in management, most likely risk factor, complications, because those are all things that step two loves to ask. And also pin questions too, is what is the next best step in management or what do you want to do next?
Yep. 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 Yeah, kind of. I think the transition, I'm presuming most people that are watching this video have already taken step one, right? The transition from step one to step two, is really like moving away from that pathology, pathophysiology. Though I did get a couple pathology slides on mine, which was, I was kind of like shook when I saw that.
Sure, yeah.
Yeah. I don't know if you got any, Noah, but
Yeah.
no, you got no pathology?
No, I got like 5 pathology slides.
Oh wow, you got more than me. Okay. Um, but yeah, it's more about like management and like figuring out what's going on next.
Yeah, well, step one ends with the diagnosis, usually what's the most likely diagnosis. Step two and it's really annoying because you'll like read the entire stem and you'll be like, oh, this is aortic dissection. And then they'll be like, what do you want to do next? And they'll give you like 5 like sort of reasonable things that you can do. And it's not just is a next what is a step in management that you could do, but the next best. So that's where really the transition point. But also so it's sort of transitioning to our experience on surgery. And you go see a patient in the ED in acute abdomen, and then you go present to your attending. They're going to ask you what's the next best thing that you want to do. And on surgery, it's usually surgery, but sometimes it's not. Um, so
I
how
feel
is
like
your
surgery is big on the image. Sorry to interrupt. I think
oh
surgery
yeah.
is big, like knowing which imaging comes next too.
That too. Yeah, how would you like to confirm your diagnosis? Hint, like 99% of the time it's like CT abdomen, but sometimes that's wrong. But you can
Yep.
almost never go wrong with CT abdomen.
Yep.
But but surgery for us, I think was it 8 weeks for you as well? Okay, so for both of us, it was a 2 month clerkship. Um, did you mostly have general surgery? Was it all general surgery?
So Penn State does it like differently. So we had surgery A, B, and C. So 4 weeks of A is like a more bread and butter one. So I think there's like colorectal you can do for surgery A. You can do like emergency general. You can
Yeah.
do I did surgical oncology, which I think was the most specialized of the A. Or you could do one at like a subsidiary hospital that we have that was like a true community general surgery. And then you had B and C, so you could pick like 2 weeks each of like neurosurgery, plastic surgery. I did like breast and endocrine surgery was a fantastic experience. Highly recommend that. I did like trauma as well for a couple of the weeks. So like you can kind of explore the subspecialties. How did it work at Mayo?
Yeah, for us, and it's actually different across the sites. Like, if I'd done my rotation in Rochester, it would have been a lot of general and trauma surgery because it's a level
Okay.
one trauma center. One of the
Okay.
unique parts about Mayo Clinic, Florida is we actually are not a level one trauma. So we get essentially no trauma. So for us, it was, and we also get a little bit more of a diversified experience. I had 2 weeks of anesthesia. I had 1 week on surgical oncology. I
Okay.
had 1 week on, I actually did not get to do hepatobiliary. So my other general surgery week was vascular. So I got to do vascular surgery.
Okay.
Um, like I said, surgical oncology, anesthesia. I got to see cardiac thoracic surgery, which was a
Oh,
unique opportunity, and then also urology. So I got a little bit more of a diversified field of the various surgical subspecialties, which was definitely, I really liked it. I think it was actually helpful for the shelf. Like, um, our clerkship director was like, oh, the surgery shelf is all general surgery. But I actually feel like having that a little bit broader of an exposure actually did help for the times that you got a urology or cardiothoracic question.
There was a lot of pediatric stuff I remember on the shelf.
Yeah, actually too.
But I think a couple of our shelves were custom. I know our IM shelf was custom.
Mhm.
And then I don't know if surgery was because one of our what I don't think it was, but one of our course directors was a pediatric surgeon. And I know he maybe it was disproportionately represented, I'm not sure. But yeah, surgery, again, UWorld, and it really helped that I had done IM. It really, really it did make
Yeah, same.
sense.
I would, and this was, I think I had even told, we had this discussion before when we were making our third year schedules about where do we put everything. And I'm a firm believer in that internal medicine should be before surgery because the surgery shelf is the IM shelf in disguise. That's what it is.
Yep, that's exactly what it is. And so there are a lot of questions, like the true surgery questions are like some X person comes in and like they bled out X amount with a chest tube, or they did this or they did that. And it's like, should you go to CT first or should you go do surgery first? Those are like the true surgery questions. They won't ask you like crazy stuff about like what like should it be a Fannin deal or however you say it? That's an OB incision, but like what type of incision? Like no.
No, yeah, you're not going to get technical questions, and I don't know about your experience, but at least on our shelf, surprisingly little anatomy too. Like maybe you had to know like the big picture, but nobody's going to be like, which artery in this step of surgery are you most worried about hitting?
Hmm.
Thing like that. It's really more of like somebody comes in with cholecystitis, what's the time frame for taking out the gallbladder? Like those types of like big picture um, questions. As
Right.
far as clinical and evaluations go, I feel like a lot of people are scared of surgeons and how I feel like they have a reputation for being mean and curt to medical students. But I actually, and I don't know about you, but I actually had a really good experience. And I think most of the time, if you show up and you're willing to learn, they're pretty nice. Um, and definitely try and work on your procedural skills. As someone going into psychiatry, I was not adept at many of the procedural skills that maybe I should have been. But what was your experience?
Um, I'm kind of, what, it took me a minute to think about it. Um, I've always been a little bit challenged in that aspect. So I'm kind of with you. It was challenging for me.
Yeah,
I'm not
yeah.
gonna lie. What was the most challenging part for you, do you think?
Honestly, I think what the most exhausting part of surgery was is you're standing at this table,
Yeah.
like you're supposed to maintain a sterile field that like nobody really explains to you, but is somehow supposed to be like understood the first day that you walk in. Then you're constantly under the spotlight. You're getting pimped on all these arteries and nerves or structures.
Hmm.
And, then they're like, okay, you're all done with the case. The medical student is going to close the incision. And then
Oh,
maybe,
that was so stressful.
and then maybe if they're not, and then, if they're nice, an intern might take over for you if you're taking long. And sometimes they'll just wait 45 minutes and let you close up the incision. That happened to me more than once where they're just like, you're just going to close this up and it'll take as long as it's going to take.
I had some residents that were nicer than others. I'll say that.
Yeah.
And so the ones that were nice, I capitalized on that, and I asked them to teach me and kind of help me, and I actually got pretty good at closing towards the very end. I actually really like the subcutaneous like running suture. I thought that was really fun, but oh man, there was a resident that I worked with who kind of had a reputation for like being quite hard on people. And I cut her knots 3 times in a row because I didn't know how to cut it because nobody had shown me. I didn't know what to do. And I very much upset her, but that's all right.
That's okay. For
Um,
those like who don't know, every surgeon is gonna have it's like the classic medical student paradox of like too long or too short for where you cut your knots.
yep.
There's also a specific way that you hold the scissors and you angle the scissors. So you
Yes,
don't,
that was my problem. I wasn't angling them right. Yeah,
yeah, if you don't angle the scissors, you cut the knot and then they have to redo the suture. So that's like a classic like medical student snafu that happens to ever. I did it
it
multiple
happens.
times.
I think it's almost a med student rite of passage to be yelled at by like a scrub nurse.
Yeah,
Um,
all the scrub nurses at Mayo were actually surprisingly really nice. A lot of them took me under their wing, and it was wonderful.
yeah.
It was nice. Yeah.
I only had bad experiences with like a couple, I would say, which I know is unusual. I know like if you read the Reddit, everyone has like a bad
Yeah.
experience. I only had like a couple isolated experiences. Again, it comes back to being eager, earnest, and humble, right? And so I think if you come in, you're like, I rule the roost, this is my OR, like that's not gonna go over well, right? But like everybody's broken sterile field. I don't know. Maybe you haven't, Noah, but um
No, this was like related, but on OB, and like and it's like and and it's the littlest things because like sometimes like it's really like a completely different mindset being in the OR because somebody's like, oh, can you like just move this thing? And I just didn't think that it didn't have a blue strip over it, which meant that it's sterile and not, and then you contaminated the
yeah.
entire field and somebody has to redo everything that you mess up or your hands go below your waist and they're like, oh no, you're now unsterile, go regown. Um, you're washing your hands and you didn't dry them enough with the stupid towels that don't really dry your hands well. And now you rip a glove and now you have to get another glove. So there's just a bunch of medical student things that it just happens.
Here's a pro tip for like making your residents like you. Find out what their glove sizes are and pull it for them because like it saves them like an extra few minutes. And I don't know about how they were with you, Noah, but like they always prized efficiency. So they were always very happy if you like did some of the work for them. So that's one thing I would say. I was on a very complicated service. So I was on surgical oncology. So I really wasn't allowed to do a lot, if I'm being
Mhm.
very honest. And I don't know how your experience was, but really outside of some like very basic retracting, I really wasn't doing a lot. And so I kind of urge people like when you're on your surgery rotation, like be open-minded. But also like if you're not having that much fun, like try to like delineate, is it because I'm not doing that much or is it because I'm just not cut out for surgery? Right. And I think like being in the OR, and I'm actually grateful for having done surgical oncology because I mean, we were in like 12, 15 hour, like robot whipples, like open hepatectomies that took like 8 hours. Like I remember I was so happy because the surgery took like 6, 7 hours and it was like, oh, wow, this is like a short surgery. Uh, but I think like it's a very good time to reflect on, do you like surgery, right? And for me, I was between OBGYN and neurology, and I think it kind of made me realize, I don't know if I'm cut out to be a surgeon. And then I did my OB rotation. It was like, okay, maybe this isn't for me. And I think it's kind of a good place to figure out, can you live without doing surgery? Because I think the old, is it adage or adage? Sorry, I'm a little bit challenged today. But the idea that if you can see yourself doing something else besides surgery, do it. I think does hold true because what
Yeah.
I realize is that the folks on surgery really like live and breathe surgery. Like that is what they are here to do, and it's amazing to watch. Like it's amazing to watch how passionate these people are about surgery, but like they will do anything, like sacrifice sleep, don't go to the bathroom, skip a few meals if it means that they get to do surgery. And I think your task as a medical student, if you're even remotely thinking about a surgical specialty, is, do I kind of fit in that headspace? I'm sorry, I know I said a lot, Noah. I don't know if you have anything to add.
No, I would agree. I think what you just said is true. I think I think medicine and surgery are both pivotal clerkships in that this is where you find out, am I a medical person? Do I like the medical management of disease or do I like the surgical management of disease? And I have to do something with my hands in order to feel fulfilled in my career. And if you are, so like if you like get over the fact of how people treat you, there's surgery culture is just different. It just is. I think I would really focus on that. Not that that's not important, but I would focus on, do you like the OR, the dynamics of the OR? Do you like doing things with your hands? Do you like suturing? Do you like cutting incisions, all the other crazy things that they do, robotic surgery. I mean, there's so many cool things to do in surgery, but it truly isn't for everyone. I think it takes a special person for each field of medicine, but surgery I feel like is uniquely different in that regard.
I will
Um,
say one thing about surgery personalities is that people are very straightforward, which I personally I really liked working with that. It's like, if someone's in a bad mood today, they're in a bad mood today. And if someone like likes teaching or wants to help you, they're like very straightforward, like I'm gonna help you. And I really like that. I did like that part of surgery culture. Yeah, I don't know. I look back and I don't feel like it was as bad as people made it out to be, right? The hours I think were probably the worst part of surgery.
yeah,
I mean, I was getting up at 4:30 to come in at 5 to pre-round so that we could round at like, 5:30 and then we would be in the OR like at 7, right? But we would have to be in there and prep and like do the patient, right? So the surgery wouldn't start until 9, but realistically you've been in the OR for 2 hours even before starting the surgery.
yeah.
Um but yeah, I also had fantastic course directors. Again, I think it comes back to surgeons, and this might be too much of a general, but I think they like it when you're direct. They like it when you're honest. And I felt extremely supported by my course directors. And I really did feel like I gained a lot from that rotation.
Yeah, I think so. I think, and both of us are non-procedural people. Like we're both going into fields
I
where,
don't know. I'm excited to do some LPs, Noah.
okay, yeah, well, I was about to say the only procedure that you're about to do is an LP, and the only procedure, if you even want to call it that, is like TMS, DCT. So we're both like not, like surgical people. But I will say, I think it's a very important experience that every medical student go through because regardless of whether or not you do surgery, almost guaranteed you're going to run into somebody who has had surgery, and knowing what that experience for the patient was like of the pre-op appointment, no, like seeing them the day of surgery and how scared they are, the actual like technical maneuvers that are required to be a good surgeon. um
Yeah.
you
I
know,
mean, this is what you send patients to get, right?
Yeah, it's what you send patients to get. So, I mean, knowing the complications, what that experience for me, maybe as a future psychiatrist, what somebody's good or bad experience with surgery is super important to see. And then also, it's just if you don't want to go into surgery, it's a time to do something that you're never going to get to do again. Um, I got on vascular surgery. We were doing an amputation. I actually got to saw off the tibia and fibula,
That's
um,
awesome. I mean,
which
not
is
for the person, but for
but
your
not for the person. But I mean, that's an experience that I'm never going to do again. I got to do vein stripping on vascular surgery for varicose veins and suturing up port sites on cardiothoracic surgery. I mean, those are experiences that are forever burned into my mind, but and will stay with me. But I think it's important. It's an important part. This is what makes, medical education so unique is that we see everything, um, and have a little bit of knowledge about every field, even if you don't end up going into that field. And that's what makes, a physician a physician.
Yeah, no, I think, you make an excellent point. But I think, to kind of bring it back to how to do well in surgery, I think we talked a
Yeah.
little bit about shelf, right? UWorld, I use DiVirgilio. I'm sorry, I forgot to mention that. I use DiVirgilio's as a textbook for surgery. I really, really liked it. Did it gain me extra points? Maybe. But I think it kind of helped contextualize things for me on my rotation. Not at all required. I think I use case files.
Yeah, I use case files for sure.
No, it wasn't case files. It was Pastana's.
Oh, Pistana.
Pastana's surgery notes. Those were really, really good. Really high yield. Highly recommend those. But in terms of getting good evaluations, I felt culturally surgery, people are pretty open. And I think it was I'm not saying like everyone is fake. That's not my goal. I'm just saying that um I think it's culturally it's very clear like who enjoys education. And so it was very easy for me to determine who to approach for evaluations, if that makes sense. Um, and I think it's okay. I'm not technically gifted. I am not procedurally gifted. It took me a very long time to learn how to suture well. It took me a very long time to do hand ties and all that stuff. I think for me, the reason why I was able to get strong evaluations is because I asked questions and asked for feedback. And I was like, hey, I want to learn how to suture, or I know I'm bad at it, like I need help. And I think because I self-initiated that, for me, it was something that they saw as a positive because I think they were very happy to see that I was trying to improve and learn.
Yeah, I would agree with that. I think in addition to like your generic feedback of, listen, surgery is already stressful enough. Don't be that person to bring the room down, is have a good attitude. Like the hours are long. You don't want to be in a 7 hour Whipple. Nobody, particularly other than the surgeon, wants to be in a 7 hour Whipple. But but have a good attitude the entire time. I'm not saying you have to show like crazy enthusiasm, but at least, be able to answer, questions during the surgery, or maybe have a few questions prepared about the procedure. I think my strategy for doing well in surgery, especially since I was on a different service every week, I nobody really got to know me for a prolonged period of time where they could really write a super strong evaluation. Was on the services where I was I'm gonna know my patients the best that I can. I'm gonna be that person to know what's wrong, their journey to why they want the surgery, their mindset going into the surgery, the medical management after the surgery. Like, be that person for the team. If you're not a procedural person, and I would be like, I knew every detail of every single patient's history going into their surgery. And I think that's really important too.
Yep. Well, I think we've covered a lot. This is a
Yeah.
longer episode, almost 45 minutes now. Any final thoughts, Noah?
No, I would just say that internal medicine and surgery, and I've said it, I think, a couple of times now, is just it's one of the hardest periods of time in your life as a third year medical student. But I think you truly do come out sharper and better prepared to tackle the remainder of your clerkships. After internal medicine, you know how to present a patient. Um, After surgery, maybe if somebody really needs you to suture something, I think this is the case for Elena. I think we could maybe tie something together, so we both got something out of it.
Yeah, I think internal medicine is kind of the intellectual exercise, right? Where it's, I can see anything, right? And I think surgery, you come out and you say, I can do anything. Like if I could survive the hours and the standing and by the way, if you have a bad lower back, get a back brace. I had to wear
A good pair of
brace.
supportive shoes too.
Yeah,
Yeah.
and then supportive shoes. But I think for me, it empowered me and it showed me that I could do anything. Um, and so that was kind of my big takeaways. So you guys will do great.
Yeah.
Study hard, make sure you start studying for yourself as soon as you can. Because there's some days you're gonna come home and not get anything done, right? And that's kind of the reality of M3. So start studying UWorld. We mentioned a couple of textbooks, Step Up to Medicine, Boards and Beyond, White Coat Companion, D. Virgilio and Pastana's surgery notes. Those are all highly recommended by us. And just make sure you show up every day on time. Do your best, even if you know you're 100% not applying to it. That's okay. Still pretend like you are, because you want to put your best foot forward.
I think there's no better way to end that than you just said. I think that's perfect.
All right. Well, thanks everyone for taking a listen. If you like what we do, feel free to follow, like, subscribe, leave a comment, follow us wherever podcasts are available, including Spotify. And we'll see you in the next one. The next one we're gonna talk about step 2 CK.
Yeah.
Once Noah gets his score back and we can give you guys some good advice there. All
All
right,
right.
take care.